It's American Heart Month, but we're going to talk about your feet. Dr. Lily Johnson is here to tell you why your legs and your feet can indicate your risk for heart attack, stroke, and amputation. Dr. Lily Johnston, thank you so much for being here. Such an important topic as we kick off Heart Month. So, most people think heart health, it's about just the heart, but you're going to talk about why legs and feet matter. Why do they matter? What do we know about heart health from our legs?
Great points, Kim. Thank you for having me back. So, of course, the heart is so important, and we all love to talk about it. I was actually just at a meeting this weekend, and a speaker got up and said, stroke is part of major adverse cardiac events, this MACE thing that we talk about when we talk about outcomes trials. He's like, but stroke isn't related to the heart. It shouldn't be in MACE. We shouldn't talk about it because you can't have plaque in the heart arteries that goes to the brain. And I thought, what a kind of narrow perspective, because we know that plaque forms in all arteries. If it's in the heart arteries, the coronary arteries, then it's also, at least to some extent, in the arteries that go up to the brain that are responsible for some strokes. And it's also in the arteries that go down to our legs. And that's how I, as a vascular surgeon, unfortunately continue to see patients when they present with plaque in the arteries to the legs that is causing circulation problems, problems with wound healing, problems with their ability to walk. And if they are unable to walk well, then they have a hard time exercising. And if they can't exercise, then it's hard to keep the heart strong and all the blood vessels strong. So this is a systemic disease. It impacts every blood vessel in the body. And that's really what I want people to take away from this for Heart Month.
I mean, we've shared stories on youtube.com/, the way to my heart, where we have Scott, for example, just recently, and he was telling us that he had leg pain for 20 years. He used to go skiing, he used to dance, and just over time, it was just less and less. And he thought it was because of old age that his legs, he would get leg cramps. And his wife, after every single exercise routine, she would rub Vapo Rub of it on his legs, which he seemed to maybe feel a little bit of relief. But 20 years of this, and it got progressively worse and progressively worse to the point he ultimately had a heart attack. He went to the hospital, had to have a quadruple bypass of his heart, and then fast forward a few more weeks, he gets out of the hospital, tries to get into rehab, and he starts having trouble walking. And he ends up with a wound on his foot that won't heal. Ends up at but podiatrist. The podiatrist says you have a really bad infection. We need to do a transmetatarsal amputation of all your toes. And it was only after going back to the heart doctor a month later, this is like now months later after the release from the hospital, the doctor's like, why has it? No one actually checked your legs. We need to send you to a vascular surgeon. Lo and behold, he had peripheral artery disease. Now, what if Dr. Johnston, 20 years prior, when he had those leg attacks, is what we call them, right? The cramps in the legs that are debilitating. If he would have gone to the doctor then and gotten a proper vascular assessment, do you think that we could have prevented the ultimate heart attack? Do you think we would have known sooner that this person was at risk of a heart attack? I mean, we know his toes would have been saved.
Yeah, absolutely. We could have made sure he was on best medical therapy. And certainly, I think there's always this paradox in people who are very active. People assume that because you exercise, you can't possibly have either blockage in the heart arteries or in the leg arteries. And they're like, well, you're very fit. I'm sure that this is fine. But we see people who have heart attacks during triathlons and during marathons. There are certain genetic predispositions to these diseases that can affect our patients. And also, there are just other risk factors that can come into play even when people are very fit. And so when you get somebody who says, well, I used to be able to walk 10 miles and now I can only walk 5 miles when my legs start hurting, everybody says, oh, you can walk 5 miles. What's the problem? Half my patients can't walk a block, much less 5 blocks or 5 miles. And I think those patients ultimately are harmed by this misperception in the medical community that fit people cannot have artery disease, and it's we know it's wrong.
Yeah, and we have a lot of patients that that do end up getting diagnosed with PAD first, right? The circulation in the legs
Hmm.
first, because they do end up reporting that they do have leg pain, and they do have a doctor that says, "Oh, wait a minute, we need to do a proper vascular assessment." But then I find the other problem where they don't check the heart. And our philosophy at the Global PAD Association is, if, you don't have unhealthy legs on a healthy person. And that's basically what you were saying. So you should get your heart checked. You need a cardiologist to do some advanced testing on your heart, because you're not going to be walking fast enough with PAD. You can't get a brisk enough walk in those late stages of PAD to get you that cardiovascular, workout that you need. And so you could just be one step away at that point from a heart attack. So, what is your best advice for patients with PAD to say, "Hey, doc, you're forgetting something here"?
I think I'm of two minds of this. So, if you are getting optimal medical therapy through your vascular surgeon and you are not having chest pain or significant shortness of breath or any other symptoms that could be related to the heart, and we're not planning a big operation, I don't know how much added benefit we get from doing advanced testing in the heart, because the evidence is not that strong that if you're not having symptoms, that putting stents in or doing other procedures is really the right answer. But if you're not sure that your medical therapy is optimized, right? If your vascular surgeon says, well, I'm not doing anything for your legs, you should probably be on some medicine for your diabetes and for your cholesterol, but I don't know what that is. Go talk to your primary. Well, then I think it's a great idea to go talk to a cardiologist who may be more familiar in managing some of those things, because I recognize that I am one of the very few vascular surgeons who really enjoys doing that side of the practice. Most of my colleagues are very well intentioned and they love what they do, but they're not as comfortable prescribing these medications or helping manage the risk factors. But that's important to help the heart as well as the legs. So that's a great reason to go see a cardiac specialist or a heart specialist. And if you are having symptoms that are concerning, like chest pain, shortness of breath, absolutely. Like, do not stop, do not pass go. Like, go immediately to get evaluated, because under those conditions, we know we can help. And if your vascular surgeon is planning a bypass or planning a procedure, maybe not if it's just, quote unquote, just an angiogram or a stent, but oftentimes that can evolve into the need for a bypass. And that's a big deal. We should definitely understand how strong the heart is before we talk about risks and benefits of open surgical procedures.
I want to throw a little wrench in there, just for a moment, just with some of our experience with some of our patients, because I had a patient, who had a foot wound, and we spent all the time. She had CLI, and we spent a year literally getting that foot wound taken care of. She wasn't able to exercise very much, and she was so excited that she was ready to go and end up to go on a walk for the first time after, being healed. And she had a massive heart attack the moment the first walk she went on. She had no symptoms because she wasn't really walking, she wasn't exerting. And we've had two people in set therapy, started set therapy, and they were pushing it. They were doing, great. They started really walking and getting up. One died, the other one had a massive heart attack. So we always tell patients that you may not know. And we have Dr. Parag Doshi, who is a CTO expert for hearts. And he said, I would rather be safe than sorry. Fatigue is the new, angina. And we're telling people, especially if they have PAD, that at least get checked, at least have the conversation with the cardiovascular doctor, at least maybe get a stress test, just so you can see how far you can really push it to be safe. So it was just his perspective.
I actually think
But
it's a
of
great
course,
point. I mean, my thought about, well, you're not having symptoms is predicated on the fact that patients are able to exert themselves, and you're totally correct. Not every patient is able to do that. I think you make a wonderful point.
yeah, I just the experience, it just makes me so sad. It's hard to tell, from a distance, and it's hard to tell from clinic, right? Unless you're out there seeing the patient exert themselves. And thank goodness with our walking program, our structured walking program, we ask the patients as well, if you're experiencing any symptoms, I don't care what they are, if you're short of breath, whatever it is. And we had Dr. Anida Dua tell us how to coach them. to really make sure that we're telling the patients to put all potential symptoms, life and limb threatening symptoms, in there, to report after each walk. And one patient out of 700, I mean, it was one, ended up, and she reported shortness of breath on one of her walks. And of course, if we see that, we report it to the cardiologist. And she had some very narrowed coronary arteries, and that saved her life. So um, I thought that was interesting. Always make sure that you do keep an eye on it and don't make excuses about it. If you are, not walking as far as you did last year, and you're slowing down, or you're thinking it's old age, or you're thinking that you have shortness of breath because you didn't sleep that night, you should always get it checked just in case. But the American Heart Association, um, back to American Heart Month, they're saying, that heart health, they just came out, I think it was this week, with research that said that heart health is actually improving overall. Um, Yet diabetes and chronic kidney disease are still driving heart problems. So they kind of say this in the same sentence. From what you see of, this type of thing, I mean, I'm thinking, that is heart health really improving if you have all of these diabetics and chronic kidney disease patients that are having all of these problems, there's these epidemics. So are we really improving our heart health, because, or are we just not checking the heart in these patients?
I think it depends on how you define health. I think if you're talking about the presence of plaque, I would suspect that is not correct. If the definition is number of people dying of heart attacks, then perhaps we are just doing a much better job saving those people who
Good
actually
point.
have an event because in my hospital, I take care of the heart failure patients, the patients who have a heart attack and get an emergency stent put in and have to have a pump to support their heart for a while. And it's pretty remarkable what we can save, like who we can bring back from the edge or beyond of death, and the ability to rescue patients who've had an event like a heart attack or a stroke has come leaps and bounds in the last decade. And our medications are better, our stents and interventions are better. So I'm wondering, I don't know, I haven't seen the paper, whether that's really a mortality issue and we're just rescuing all these people who have events versus a way that we're counting the number of people with plaque. Because I agree with you, the number of patients with diabetes is going up, our obesity rates are going up, and I have to imagine that the presence of plaque has not changed a lot.
But a lot of our medicines are pretty good now, and even with the GLP-1s, and I think is it Manjaro that also helps, or is it, there's one with a Jardiance is supposed to help with, and these are supposed to help with uh, your heart as well, I would imagine.
So the SGLT2 inhibitors, those are the like Jardiance medications. Those are for diabetic patients and they help the kidneys excrete sugar into the urine. They do have a significant role in the treatment of patients with heart failure and at risk for any kind of cardiac disease. So does a diabetes reversal type of nutritional strategy, right? If you don't have a lot of
Yep.
sugar in your blood, then maybe you don't need a drug to pee it out. So I wouldn't discount the importance of lifestyle in the fundamental management of these diseases. However, if you are struggling and in an acute process, yes, SGLT2 inhibitors like Jardiance are a good choice. The GLP-1 receptor agonists are also a good choice, and that is true in patients with diabetes, but also who have a diagnosis of obesity without a diagnosis of diabetes.
And I know the patients are not going to like me saying this, but um, we have had quite a few new statins come on the market, and Repatha, and a lot more people on statins today versus, let's say, 50 years ago. Do you think that that may be playing a role in improved heart health?
I think that our awareness of the role of lipid lowering therapies, so Repatha and Praluent are lipid lowering drugs. They are not actually statin drugs. They are a different
Oh,
class of medications. But we have papers that talk about the percent atheroma volume or the amount of our arteries that is diseased with plaque, and we can reduce the amount of real estate taken up by plaque when we have lipid lowering therapies that are very aggressive and get our LDL-C lower than our historic targets were able to achieve with just the, sort of first and second generation statin medications. I think it's absolutely true that those have contributed in part to an improved ability to rescue patients with terrible plaque and terrible disease. Again, is it, I have a lot of people comment on my channel, well, like 40% of the population's on statins and heart disease is still the number one killer. Like, obviously they don't work. I think that's a more nuanced question, but certainly we cannot refute the evidence that atheroma volume decreases on aggressive lipid lowering therapy. So whether they prevent heart attacks or not, we are certainly able to stabilize plaque and reduce plaque volume with aggressive lipid lowering therapy. And for the patients who are severely impacted, I think it's a great additional tool for us.
So as we close out here, heart health, leg health, I want to, drive that home. There is a tie between the two. You mentioned at the beginning, it's all systemic, right? So why are we still seeing this great separation in our healthcare system between heart health and leg health when they literally um, should be tied together across the board? Vascular should check with, cardiology. And I know that we talked about the nuances there, but also, for people who have a heart attack, but, they should have their legs checked as well, because we have had a lot of people that have gone in for heart issues. And then they end up, one in particular, I'll tell you just because it's top of mind, is Benny. I just interviewed him, and Benny ended up with endocarditis and ended up, and he was in the hospital for a while and had a valve replaced, and on and on. And during that time, while he was laying there, he ended up with a pressure wound on the back of his heel, and he had some achiness in his legs that he couldn't figure out why. They did a venous ultrasound to make sure there were no blood clots or DVTs. Within a week of getting out of the hospital, he really couldn't walk. I mean, he had leg cramps like you wouldn't believe. And it turns out that he needed his legs checked, that he, thank God, was referred, that his heart doctor, actually, he went back to the heart doctor right away and he referred him to a vascular surgeon. But that doesn't happen very often, and we see it over and over again. We have a woman, it was actually one of Anida Dua's patients that we ultimately got her to. It was a little too late. She ended up losing her leg, but she had a heart attack. And despite having, diabetes and everything else, they never checked her legs. But her legs were really her initial complaint.
Mm,
And then she ended up in the emergency room on her doctor said, "Oh, yeah, I know you're fine. You just need to lose weight." And she goes and she has a heart attack. And that's, when ultimately she went home and she couldn't walk. And it was just too late for her. She had to lose her leg.
yeah, that's
So,
a very sad and unfortunately not uncommon story. And the other thing I will add is, we all say, well, but heart disease kills more people. P.A.D doesn't do that. But every patient that I've ever taken care of who had a complication from a peripheral bypass in the legs, if they had a heart attack and they were, had that as a terrible complication and expired, well, their cause of death is heart disease, not PAD. But guess what brought them in the hospital? And guess what started the whole sequence and chain of events that led to the heart attack? It was the PAD. So again, it's a systemic disease. If you have it in the legs, you probably have it in the heart. If you have it in the heart, you probably have it in the legs. And if there are issues, complaints, concerns, like pain, like non-healing wounds, then that is an absolute reason to get checked.
yeah, we always say two fingers, on the pulses could actually save life and limbs. So when you go to the doctor, take off your socks. Ask them to feel your foot pulses. I mean, it could save your life and your limb.
Absolutely. Great
Thank
advice.
you so much, Dr. Lily Johnston. And we do at youtube.com/the ad sign, the way to my heart under our shorts. We do have how to check your feet at home with Dr. Lily Johnston. So check that out. But you can also go to Lily Johnston's page. She has other great content on her page as well. YouTube.com/, the @ sign Lily Johnston MD. And make sure you subscribe to her channel and ours. And next week, we are going to be talking about the different types of plaque that's actually blocking your arteries. So hopefully you'll join us then. Subscribe to our channel to get notified when that pops up. Have a great week, everyone.